All right, we are now recording, so let's jump in. For those that I have not had the pleasure of meeting, I'm Morgan Cole. I'm the Director of Children's Integrated Services for the state team, normally in Waterbury, now spread throughout the state. I want to thank everyone for joining. I know that there is a lot going on in everyone's lives personally and professionally right now. I think this is the first opportunity that we've had to bring together so many of our direct service providers in the CIS field all together since the beginning of all of this. So I'm excited about that opportunity, and I really appreciate everyone taking the time to call in today. As I said, a couple of housekeeping things. Please make sure you're muted. I'm still hearing a little background noise, so if people could mute themselves, that would be great. And we are recording this, and we'll share a link or other ways to access the recording afterwards, so that for those that weren't able to join today, they'll be able to hear the information. So the goal of today is really to talk about restarting in-person service delivery for CIS services, and specifically walking through guidance from the health department about what that looks like in order for it to be done as safely and rationally and gradually as possible. So as implied by the word gradual, one positive thing about this is that we will be able to take a bit of a phased approach that will give us the opportunity for you as direct service providers to use a level of discretion in determining to some extent which clients make sense to begin seeing in person and which should really continue to be served remotely. So I'll hand things over to our guest, Monica Ogilvie from the Department of Health in a moment, but just to give a little bit of additional context, this guidance was developed for home-based service delivery overall, so home and community based. So this was developed with input from a series of partners involved in that type of service delivery, working with VDH, and that's to ensure that there's as much consistency as possible across those home and community based services. What that does mean is that the guidance is not specific to any particular program, including CIS. So part of our goal today is to walk through that guidance at a high level and then provide the opportunity for you to all ask questions. So some of those we will be able to answer in the moment now, and some of them are going to be things that we need to take back and then follow up on, and others may be things that haven't been considered yet, and that there will be real value in having that input from you all in terms of what are the things that haven't been considered yet, or gaps in the thinking so far that we have the opportunity to follow up on and do some additional thinking and get further guidance out to you all. I also just want to be clear that really our focus for today is kind of the public health aspect of that guidance. So there will inevitably be very reasonable questions around some more of the administrative CIS specific details, like how do I bill for services, or how should this transition back to in-person service delivery be reflected on clients' one plans. Those kinds of things are really important for us to hear and to get guidance to you on as well. So we're happy to collect those questions through the chat box if they come up, but we really want to maximize our time with Monica today from the health department so that we can focus on that public health side of things. So that's what we'll be generally focusing on today. And then lastly, before I hand things over, I know that at the forefront of many people's minds right now, understandably, is the question of PPE, of personal protective equipment, and cleaning supplies and those sorts of things. And that is addressed in this guidance and existing guidance on the VDH website in terms of, to an extent, what is appropriate to use and how so and all of that. However, I know there's a lot of people wondering, where is that going to come from? What if I'm having challenges getting adequate PPE? So I want to say at the front end, because that's something I anticipate a lot of questions will be around, we are working on compiling resources for the CIS field around those needs. Unfortunately, there's no one single one-stop shop for all of that. However, we are tracking down resources to either, in some cases, provide to the field directly, free of charge, some of that. So for example, we anticipate being able to provide cloth facial coverings, cloth masks, to all CIS direct service providers in the coming weeks. And then for other things, being able to give you guidance on where those can be accessed if they're not something that the state can directly provide to you. So more information to come on that, and I wanted to share that right at the get-go. All right, so Monica Ogilvy, do we have you on the line now?
Yep, I'm here. Hi.
Wonderful. Okay, so I'm going to hand things over to Monica. And Monica, if you could introduce yourself, and then I'll bring up on the screen the guidance itself if you want to refer to that at all. Everyone hopefully received the link that was included in the calendar invite for this webinar and can access it and bring it up as themselves.
Great. Thanks, Morgan. Oh, man. Someone's got a good ringtone. Okay. So we'll just ask that folks put themselves on mute. And we'll get started. So my name is Monica Ogilvy. I am the Clinical Services Director. The public health program out of Child Health. So most of the time that my team members. Oh, people are saying they can't hear me. Monica, you are cutting out. Okay.
And Monica, you are cutting in and out.
Let's see. Now?
That is better.
Okay, it must have been my earphones, my earbuds. How about now?
Yes, that's much better.
Okay.
Thank you. That's way better than it being a problem with the connection itself.
No, it's all good. Technology is so straightforward. So my day job is working at CSHN. However, for the past 10 weeks or so, I've been one of the leads for the state's contact tracing efforts. And even though that's not explicitly related to this discussion today, I'm putting that out there just so you know what my role has been in the emergency response. And in case you have questions about contact tracing and what it is that the state does when they identify somebody who is positive, I'm happy to address those questions right now because it really is related, because the idea here is that we're trying to slowly and thoughtfully restart services so that we're not putting people at risk. And so the other flip side of that is, well, what are we doing with the people that are positive or are in contact with somebody who's positive, so that we know if we know if we're going into their homes or if we've been in contact with them. So it's all sort of related. So feel free to lay those questions on me too, because I feel like I spend far more of my time leading contact tracing efforts than I do anything else right now. And I think that will probably be what life looks like for the foreseeable future. So let's see. Checking the chat box. Okay, people are saying they can hear me now, but one person, Trisha, is having an echo. It looks like
I think it
others.
might be something on Trisha's end. You're okay on
Okay.
my end.
Great.
And Monica, I'll keep an eye on the chat box if that is helpful to you, and give you a little alert if there's
super helpful. That'd be great. And also, if you have a second to jot down questions that might come up that I don't know the answer to, because that will inevitably happen. So when services shut down, it wasn't exactly a coordinated effort. I'm sure many of you felt this. And it was just sort of like a big whomp on the entire state where everything just shut down and slowed down really, really quickly. And there wasn't really any coordination or organization around that. And that's okay. We were in the face of an emergency. We're trying to, on the reverse end of that, be a little bit more organized and thoughtful in our approach. And so somehow I was the lucky recipient of the task of pulling together some guidance on how to restart our home-based delivery services, our service delivery. And this really started with the intention of meeting the needs of services and service providers that are serving kids and families. But I know that there are lots of different organizations and entities that are going to be serving entire families. And so you'll be navigating how to apply this guidance towards maybe a child or a youth in a home that you are serving. And then you'll have different guidance that might inform how other providers from your organization are engaging with parents or adults in the household. So those types of scenarios are going to come up, and we are going to have to manage a lot more gray and unknown than we are really straightforward, clear scenarios. And so I just want to name that up front, because like everything throughout this pandemic, it is it's a lot of art and a little bit of science. So we just sort of put that up front. But if I don't know the answer to one of your questions today, I'm really, really happy to go and find it if there is an answer. So like Morgan said, we've had a lot of input into this guidance. We've been meeting with Agency of Human Services leadership. We've been meeting with some of the organizations that are delivering services on.
Monica, we lost you, your sound.
That we have landed on something that will hopefully be a helpful framework in which you can plug your work. So we'll be thinking mostly about the CIS package, obviously, today for the purposes of our discussion. So I'm going to start with really the key points here, which are right in the beginning. You know, I think many of us have identified opportunities that have come out of this pandemic and this situation. And ultimately, restarting these services is going to be a massive effort in prioritization, communication, and collaboration. So all of those things that we have worked for into this restart practice. And what I mean there is, it may have been that prior to services stopping, there were 10 home providers going in and supporting a child and their family. And we're not necessarily going to just restart and have all of those 10 providers going into the home again as they were before. The other piece to that is there wasn't always an awareness of who else was in the home on the part of the family themselves, on the part of the other providers. Nor was there always an identified lead provider or a lead care coordinator or a lead case manager or a lead of any sort. So we want to be mindful of those scenarios and circumstances, because this is an opportunity for us as a community of service providers to engage with one another to identify who is really the priority based on the needs of the stated needs of the family. And there might be circumstances where we need to override what the family might believe are their needs, and it might come down to a safety intervention. So who's really the primary and who's the priority, and what's the priority service, and how do we communicate with one another in order to get services to the family without inundating them with humans, and thereby increasing everybody's contacts and increase in risk and exposure for this virus. So I will pause there for a moment and see if anybody has any questions or thoughts before I continue. All right. So the key points here, hopefully, all along, despite a
Monica, can we
pandemic.
pause for a second?
Sure.
We've got a question coming through the chat box. Kate Ross is asking, so does this mean we may be utilizing the primary service provider model?
The primary service provider model is specific to CIS, right?
We have a primary service coordinator who plays that central role. I think the question gets to the broader point of whether or not, you know, there should be limits to how many people are actually going in the home and having that be more of a hard and fast rule. Kate, if there's something else in there that we're missing, if you wanted to elaborate.
This is Danielle. So the primary service provider model is where you have one or a limited number of people going in, and other people with other expertise transfer some knowledge around delivering their service without going directly in. So that person holds additional expertise through consultation and support from other experts, but those experts are not the ones delivering the service. The person in the home is the one delivering whatever that activity or service might be. That's the primary service provider model. Okay,
perfect. So I don't know if the primary service provider model is terminology that's universally used throughout all of AHS home services. But it's really good to have that framework. You know, I come from a palliative care background, so we work in an interdisciplinary model a lot where we sort of say who's the primary working with this family and transfer some of our skills so that we can leverage each other's expertise, but not have to be everywhere and be everything to everyone all the time. So it sounds a little bit similar. I think that's a great model and a great framework to work with. I mean, because the bottom line here is, if the service and what you are doing can be provided remotely and still obtain the desired outcomes, continue doing that indefinitely. Continue doing that until told otherwise. And that's not to say that there is less value on those services that are being provided remotely. You know, like, I'm very open and transparent about how I have felt since this has started. I don't ever want to get in my car and drive to Montpelier for, you know, face-to-face counseling ever again. It's working great on my computer and it saves me gas and mileage. So, you know, it's one of those things where it's not about the value of the service, but if the intention and the outcomes of what you are doing can continue to be achieved remotely, then continue doing so indefinitely until told otherwise. For example, the team that I work with of medical social workers over at Children with Special Health Needs, there are very few things that we feel like we have to do in person. And so our plan is to continue work remotely for the time being until told otherwise. And unfortunately, I don't even have a timeline of what that might look like. We're slowly entering phase 2 of this pandemic, which means we have a relative amount of control over the spread, and we are actively flattening the curve and working towards obtaining a vaccination. But we'll be in phase 2 until we have a vaccine and until we start vaccinating the population. So we're talking about more like months to a year, maybe years plural, versus weeks to months. So plan and prepare and settle into the remote work. If your services and the outcomes of your services cannot be achieved remotely, then we have to think about how do we then get you into the home or get your service into the home in some way, shape, or form. And that's where the collaboration and the communication works, because there might be several services that need to go into the home that can't achieve their outcomes remotely. So for example, you know, there's quite a few services through DCF where they, through Family Services Division, where they need to go in to do safety checks, things like that. They have to enter the home really to do that, to accomplish that type of service. But do they have to go into the home to do it? Or if there's somebody going into the home, can they step in and provide some degree of assurance to Family Services Division that, you know, yes, the home seems to be sound. I'm speaking outside of my scope. So if I'm butchering the description of that service there, we can go into that further. But the idea here is that if there's multiple people that need to achieve their outcomes by having really in-person interactions with the youth and family, then can those people who all need to be in the home coordinate with one another to see if there isn't some opportunity for collaboration and how that happens? And then how do we bring all that information back to the team who might, for an indefinite period of time, not be going into the home?
Monica, we have another question around kind of the primary service provider model and approach there. Wondering, do you have an idea of what that would look like with CIS nursing? It's often hard to transfer knowledge to non-healthcare providers. And I think I'd like you to give your thoughts on that, certainly. But I think one thing to keep in mind is that that's not going to be feasible or appropriate for all services, all families, or all service providers. So in some cases, that might be very appropriate and reasonable to do. And in other cases, it won't, because you wouldn't expect someone to be operating outside their, outside their scope of training and degrees and all of that. And I think the medical instances are one good example of that, but certainly there's others as well. So I think, Monica alluded at the beginning that there's going to be some areas of gray with this, and that's probably going to be one of them, where there's a judgment call to be made about, is this an area where we can reasonably utilize that model, or is it something where that service delivery needs to continue to happen separately by different providers, remotely or in person?
Yeah, and I'm glad you asked that question, Christina. Understand your dogs and birds situation in the background, so thank you. There's not going to be any sweeping guidance for any one service provider. So we're not going to say CIS nursing and now you're in go. Family services division, now you are in go. Early intervention, now you are in go. It's going to be very family and case by case dependent, because some of those some of the supports that nurses are providing through CIS nursing might be able to be achieved remotely. But I know this would be outside of the CIS bundle, but accessing a port and doing a transfusion, a medically necessary service, that obviously can't be accomplished remotely. So that's something where we would have the nurse go in and provide that service. So it's going to be a very case by case situation. There's no broad sweeping guidance for any one program that they have priority or that they get first pass to start services before any other services, because it's based on each family. And we want to involve families in what they think is the priority service at all times and whenever that's possible. So I think that those are some pearls to hold on to here. Let me see what other questions we've got here. Let's see. If we're imparting knowledge from one service to give to another provider to go in and provide in-person support, will we be able to bill for that time in some way? Margot, that's a great question. And I think that would be a great question for Morgan and your CIS leadership, because I'm not exactly sure what the requirements are around billing. I know that generally speaking, Medicaid has allowed for a pretty supportive model of payment for telework lately, or telehealth.
Yeah, so I think I would put that in the category of the kind of CIS administrative type questions that we will definitely follow up to get you some clear guidance on that, because I recognize that's real time that you would be putting into providing that consultation essentially in advance of a visit. So we'll figure out how to give you good direction on that.
So Kelly's asked a question about, is there a date that CIS would start providing new evaluations, new services, new referrals for some of the therapies, for example? Yep, we can start doing any of that now. We have the green light to slowly start visiting homes as soon as programs feel equipped. And as soon as they feel like they've had time to really get grounded in what that means for them as programs, as professionals, and as humans that have to go back into their own home sometimes with vulnerable populations. So that's another layer here. So that can happen now. But again, I would really implore folks to say, is what's being requested something that requires an in-person evaluation? Obviously, for things like PTOT, SLP, often the answer is yes. Is there someone else in the home that can somehow help coordinate and support that action? If the answer is no, then you need to get in the home, and that's completely fine. But it's really good to maintain an awareness of who else is in that home, because it impacts everybody's risk, and to coordinate with them and see if you can't work together.
And Danielle, I'd actually love if you could chime in for a moment. Danielle has done a lot of work on our telehealth guidance, particularly those related to early intervention services. So she can remind us around what the rules are with which of those services can be delivered remotely at this point, which, as Monica said, if they can be delivered remotely, they should continue to be delivered remotely unless there's a compelling reason otherwise.
Exactly. And I put my camera on. I relate to the person who said they couldn't unmute because of their animals. My cats decided that they need to get all the birds outside the house and climbs all over. So I apologize if you see a cat. So yes, evaluations still should be done using telehealth as much as possible. And the one guidance that we gave before is around the need to establish a 25% delay as a child nears their 3rd birthday. So if that's the case and you need support to establish that by eyes on, what we talked about in the home visiting is that you can work with a service provider who may already be going into the home to serve that child for whatever reason and see if they can observe what it is that you're having difficulty observing remotely. And if not, then it does not necessarily, but it may be a compelling reason to provide an in-person portion of that evaluation. But the purpose of getting the telehealth billing allowed to be done for evaluations is to enable you to continue to be able to do those as much as is possible remotely.
That's
I've got
great.
another question here from Jenny Moon around the child care guidance, stating that services can enter child care. So wondering about PPE requirements and pointing out that if children are in child care, there will be limited time for us to use telehealth with parents. I think all of this really gets to the reality that it's both good and bad, that there's a level of provider discretion here and the need to attune to individual families' circumstances and needs. So, there's not blanket rules or dates of these services start being delivered in person on this date for these providers or these families. There's going to need to be a level of discretion and working with families to figure out what works best for them.
Absolutely. And I might also chime in because it sounds like there's a question there about what the Ppe requirements are. The Ppe requirements are outlined in what I think is actually a pretty helpful document. And I don't mean that to sound snarky because we do lots of things that are helpful, but there was a document created in partnership between Dale and VDH to really outline what the Ppe requirements are. You could Google personal protective equipment, Vermont, COVID-19, and I think that it would probably come up, but I will make sure you don't have to rely on the Google, and I will ask Morgan to send out that guidance afterwards.
It's also embedded.
Sorry? Oh yeah, it's embedded in the guidance.
The link is embedded in the guidance, so I can actually bring that up on the screen now if that's helpful to reference.
I forgot we were that smart in the development of this, see? So it outlines really when you have to be using, say, like a cloth facial covering, which, by the way, is the preferred nomenclature. We're not supposed to call them masks. They're cloth facial coverings. Masks are more related to a healthcare like a healthcare situation, like it's in a hospital situation, those surgical masks that are generally disposable. So so the PPE guidance that's come out really does lay out in what circumstances and scenarios it's appropriate and to wear a cloth facial covering when you might need more. My suspicion is that for the vast majority of your services, if you are entering a home where there's been somebody who is actively awaiting test results or who is in the process of isolating or quarantining based on test result or exposure, you wouldn't be going in the home. That to me seems like a situation where you wouldn't bother. So really it's cloth facial covering or you're not going in the home for the vast majority of you. For people that are providing, say, medically necessary services, that might be a very different circumstance. So follow-up question here from Jenny Moon. Due to us being located at the hospital in Bennington, we are being told to use PPE, gown, mask, gloves, face shield, and masks. I will share this guidance with my supervisor, but we still may be asked to wear full PPE. And that sounds like that's at the discretion and the direction of the Bennington Hospital. I sure hope they're providing that PPE if that's a requirement that they're making of you. So, Morgan, I know that you were going to pull up the PPE guidance, but I wonder if it actually makes sense for us to take a gander at the framework that we put in the home visiting guidance, restart home visiting guidance.
Sure. Yeah, I can go back to that.
Great. Such good questions. Thank you. So we've got another question. I'm reading them out loud for the benefit of folks who might just be on the phone. If it is guidance and staff refuse, it is not the law, right? I am not suggesting this is a good idea, just wondering. That's going to be at the discretion of an employer. Yeah, I think that's a conversation one needs to have with their employer to refuse masks. I think we would need to the employer would need to understand a little bit more about what's behind that. But no, it is not a law. So policies should be worked on. Yes, policies should be worked on around the utilization and implementation of PPE use. All right, Morgan, did you pull up the guidance or am I just not seeing it?
I believe I'm sharing the right screen. Can other people see that?
Yes, I see your screen.
Okay.
So weird. I'm just seeing a still of Morgan's face, which is lovely.
Not as helpful as the guidance, though.
Monica, if you click on your screen where her face is, sometimes that will reactivate the screen share that she's got up.
Okay. That's not working. I don't know. The Teams is still elusive to me. That's okay. I happen to have it up on my own computer. Let's talk about let's talk about what comes after the key points. So the key points really coordination. If you can do it from remotely, keep doing it. If you've got to go in the home, let's collaborate and coordinate with our partners. And that number 4, that all home-based services must strictly adhere to all of the health and safety guidelines to limit spread. So if we scroll down and we say, okay, where do we really see ourselves in this restart? We've got a framework here, a table here with 2 columns. On the left is the priority/phase, and on the right is the criteria. The priority would fall under high, moderate, or low. The phase is going to be phase 1, 2, and 3. There's also a phase 0. We didn't put that in here. Phase 0, these phases are really what are part of the national structure, so what's dictated by the federal government and the CDC. Phase 1 is significant controlled transmission. That's what we are in right now in Vermont. We are tiptoeing towards phase 2, which is the moderate controlled transmission. If things continue going the way they are, we suspect to be fully in phase 2 of transmission of this virus by around June 1, which is why June 1 was the date given for, say, childcare to open up for non-essential workers. So
Monica, you've cut out.
Shucks.
You're back.
I'm back?
Yeah.
Great. All right. Let me know if I cut out again. I will continue to speak up and hope that the internet gods are behaving. So phase one, we're in phase one. We're towards the end of phase one. As you can see, the criteria for services that would be continuing in phase one are the ones where we're really having significant behavioral mental health concerns, requiring in-person skilled services. So again, I use that example of like accessing a port. You know, that's not something we can do remotely. Some people have life-sustaining treatments that they needed to continue getting. Obviously, those types of medically necessary services continued. And then there were quite a number of, especially family services division type services and home services through DCF that continued throughout the pandemic. Because again, it's all about weighing that risk versus benefit, that benefit versus risk. And there was clearly more risk to not be going into those homes at that time. So now we're sort of moving into sort of a phase two where we have moderate controlled transmission, where we don't necessarily think it's just community-wide spread, where we actually do feel like we can have pretty aggressive contact tracing and to really identify those people that are positive, shut them down, shut down their direct contacts, and hopefully keep that viral load contained. So I'm just going to pause for a second. Any other questions in the chat box that I should be addressing?
We had a question just for the benefit of folks on the phone about the differentiation between early intervention versus other services, and early intervention being considered an essential service, and that is considered essential due to the federal mandate to provide those services. But to be clear, that does not mean that it needs to be or should be provided in person if that is at all avoidable. So at this point, there's almost no circumstances in which services should be delivered in the home.
Correct. So then we got another question. Did you say that phase two will start 6/1? Sorry, it's cutting in and out a little bit. So again, a little bit of the art and science here. We suspect that Vermont will be in phase two around June 1, which is why we've been slowly opening up more services and why childcare centers are opening up around June 1. So, you know, we look at the data every single day. There's aggressive testing happening statewide, especially people that are asymptomatic, and that's giving us a very that's giving us a more complete picture, I should say, of what the viral load looks like throughout the state. And fortunately, we're not seeing a ton of secret positives that we didn't know about. So in other words, at these pop-up sites where people can just show up and get tested, anyone can show up and get tested, yourselves included. You know, you can schedule an opportunity to get tested, walk on out of there and get your results. And we're not seeing that a ton of people that are asymptomatic are positive. So we don't have reason to believe that there's really a lot of community spread anymore at this time, but potentially as things reopen, we could see more. So the plan is around June 1, we should be in phase two, and that's when we would expect to see more services open and when we can relax some of the requirements and restrictions that have been happening. But it's good for you all to be aware, because that means the people that you're going to visit might be relaxing their practice. They might be involving more people into their circles and into their spaces. And it's important for you to feel like the homes that you're going into are following VDH's and the CDC's guidance. Because if they're not, and you feel like you're putting yourself at risk, then those are conversations you should have internally as an organization, and certainly look for leadership support as needed. So in sort of looking at this guidance and this grid here, you know, we originally had a third column where there were examples of work and services, and ultimately decided to scrap it all together because the examples were almost bogging people down and thinking, well, what service which one is mine? Am I moderate? Am I phase 2? Do I get to start providing my service in phase 2, using like the CIS nursing example? Or, my team of social workers at CSHN were saying, well, what are we? Are we low priority? Are we phase 3? And again, we're not expecting that any one service or any one program or any one team is going to fall squarely into any one of these categories. It's really looking at the risk versus benefit to that child and to that family, and then also to the providers going into the home. So again, it's going to be a case-by-case circumstance. But what we hope you can do is to look at this framework and say, generally speaking, do we have any services or supports that we're providing that would fall into, say, phase 1? Or do most of them fall into phase 2? Or do some of them fall into phase 3? For example, at Children with Special Health Needs, our medical social workers, we feel strongly that for the vast majority of our families, we're going to fall into low priority for in-person visits and fall into phase 3. So we don't anticipate going to do in-home visits for a long time for a variety of reasons. Number one, we can achieve all of our outcomes remotely. And number 2, we want to create space for those folks that do need to go in the home to do so, and just limit risk and exposure for the community as a whole. So there's that added layer of sort of thinking about everybody and altruism there as well. So hopefully CIS and providers can see where they generally might fit into this framework, and then apply more of a case-by-case scenario with each one of the families they're working with. I'll pause for questions. Anything I'm missing in the chat?
Yeah, so we have a question from Kelly saying, could evaluations be done in the home, but then services provided remotely to limit risk for the families and providers?
So I would ask, does the can the intent of the evaluation, can that be achieved remotely? I mean, yeah.
This is Danielle. The guidance that we've given to the field is that in most cases, because eligibility for CIS and for early intervention specifically can be achieved very broadly, we have a very low standard that needs to be met, that most often that the intent can be met without needing to be in person.
Okay, so to answer your question, could an evaluation be done in home and then services be provided remotely? I mean, I don't see why not. But even that evaluation happening in the home, does that evaluation need to happen in the home? Is there somebody else in the home that you can coordinate with and have them complete different parts of the evaluation? Can you leverage technology to sort of guide a human that's in the home to say, can you help me with this intervention or evaluation? I don't know, because I don't know the specifics about your service. So this is where Morgan and Danielle are going to be really helpful in applying the specificity of your requirements.
Yeah, so I think I would just echo that if a service can be provided remotely and still have a reasonable degree of effectiveness, that should continue to happen. And I completely understand that in a lot of cases that there is something lost in not having that in-person service delivery in terms of establishing that initial relationship and picking up on things that are harder to pick up on when you're doing it through a screen. But if it is possible to effectively provide the service remotely, that should continue to happen for the time being. If that is not possible for one reason or another, whether it's something that's not billable through remote methods, or there's something in particular about that case or that family or that service that really does demand it be delivered in person, then that would fit into that second phase category, where I think taking that approach of if it's the instance of an evaluation that for some reason needs to be delivered in person in order to be effective, then doing that in that approach and then following up with remote service delivery on an ongoing basis would be appropriate. We've got a couple more questions here. So Heather Lumsden pointing out we can do most evaluations via telehealth, which, yep. Joe Ferrata is sharing from a question from home visitors or a comment saying sometimes we aren't aware of what other providers are in the home because the family has difficulty in knowing and sharing who's in their home. Is there going to be a more streamlined way of knowing what other services are involved because they keep saying finding someone else who's already going into the home and maybe they can get the information you need so you don't have to put yourself at risk? Who's the quote low man that gets to go into the home and gather info for all the other service providers? So yeah, there's some very real logistical challenges of operationalizing this. And I think I'll let Monica share her thoughts on that. And then, you know, I've got some thoughts specific to CIS as well.
It's interesting because this is where the rubber meets the road on how well we've been doing as community providers and developing strong relationships with other community providers that we might be doing work alongside with. And I don't mean that in a negative way at all, but we're certainly seeing where there's some communities that say, we've always done this. This isn't really anything new. We've always coordinated our home visits. We're going to continue to coordinate the home visit, and just a lot less of us are going to go. So there's some where this has been a really, this has had a minimal change in their general practice, and then there's some where they've just said, we wouldn't even know where to begin. So, you know, I think, you know, looping back to a patient-centered medical home, if they have one available, identifying if they have a care coordinator there, knowing things like if they're enrolled, if they're attributed to the ACO, and if they have an ACO, if they're care managed through the ACO, finding out if they have a CSHN care coordinator. I mean, it's going to take a touch of sleuthing if you don't already know who their team is to find out who their team is. And I imagine that might be a little bit more challenging for newer referrals, but hopefully for families you've been working with for all along, you have some sense of awareness of who else is in the home because there's an opportunity to, because hopefully you've been working together all along. Pam McCarthy, I love you. She says, what an opportunity to really become more integrated. There she is with my rose-colored glasses. I couldn't agree more. And then I hope that we all get a shared electronic health record or database through this process. That would be my pandemic dream. So let's see, any recommendations for supervised visitation programs? Amy, I'm assuming that question relates to, DCF and supervised visits in that regard. Is that what you're talking about?
So actually it's supervised visitation for families who have been asked by the court to have supervision due to violence, or there may not be DCF involvement.
So I wouldn't consider myself the subject matter expert on that. I think
so I can jump in for something on that as well. This is, you know, timely because actually as a CIS team, we were just talking about this morning about the need for you know, clear role delineation in what you're delivering through the CIS bundled contract as part of, you know, Children's Integrated Services, and how that interacts with FSD involved families and requirements and all of that. So in terms of supervised visitation, if I'm understanding you correctly, are you referencing that as something that would be a CIS activity?
Not per se. It's not a CIS delivered. It's community based.
So I think probably FSD would be the right place to ask those questions. That said, obvious that wouldn't be a function under the CIS bundled contract. However, obviously there's a lot of overlap in families that are served, and particularly as we talk about increased coordination between different folks going into the home. There is going to be a bit of a fine line in terms of, Monica, when you spoke at the beginning of this about if FSD really needs to make sure that they can ensure a child's safety and well-being in the home, and someone's going to be going in the home to deliver a service and then can confirm that for them. That may be appropriate in some cases, but we also need to really make sure that there is that role delineation. CIS providers are not FSD workers. We do not want to put you in a position of being while you are mandated reporters, it is not appropriate for you to be asked to, be the eyes and ears of FSD or anything like that. So just being mindful of that role delineation as you go forward will be important. There's a couple other comments in there that I want to draw attention to. So Jenny Moon shared that we've been doing this with the nurse who's been going in, having her help complete the evaluation by providing her with a bag of evaluation materials and then getting on the telehealth while she's there and directing what needs to be done. So I think that's a really wonderful example of that kind of collaboration and creative thinking. And Jenny's also pointing out that that does put additional burden on the provider, in this case, the nurse going into the home, who's already doing a lot and has a lot on their plate and maybe feeling overwhelmed. So using appropriate judgment with that and finding the right balance will be good. Do we have, I thought there was another one. Oh, I think that's it. Monica, other thoughts from you? We've got about 7 minutes left. So Monica, if there's other things that you feel like are really vital to share or other questions. We've got a question around CIS considering masks with plastic covering so children can see mouths. That is something that we've explored a little bit, and I haven't been able to find a resource for that to date, but we'll continue looking, and I do encourage people to look into that if that's something that they're able to access through their organizations. So those are the masks that have a clear portion at least, which is particularly helpful in some instances. And the question of would CIS reimburse for these? So I do want to be, oh, and Donna says I have someone making these. So Morgan, contact me for those masks. So I'll follow up with Donna, but it sounds like there's some potential resources out there in the community around those. The CIS Retainer Fund is set up, and this is something that fiscal agents and CIS coordinators are very aware of. That does have an opportunity for regions to request reimbursement for costs associated with COVID in terms of those required in order to meet the requirements of the CIS contract and deliver services. And there is a place in there to request reimbursement for PPE if that's something that is needed and the state isn't able to provide. So we would be considering those requests in the retainer fund applications. That said, there is a finite amount of money in the retainer fund. It's hard to know at this point when that will run out, but we will continue to get that out to regions to support them in their COVID response as long as we're able.
And I will say that's been a hot topic with our EDI partners, the Early Hearing Detection Intervention Program, and certainly lots of childcare providers, because how are we supposed to help children develop language without the ability for them to be able to see our mouths when we're speaking with them? So it's unfortunate that it's coming down to a grassroots effort, but there are some happening across the state. So I'd be curious to hear more about Donna's contact, and we've been really impressed to hear what different communities have been able to pull together for local childcare providers and for service providers. So the last thing I would highlight is, at the end of this guidance, we really are explicit in the discussion around and recommendations around collaboration and coordination. This is not going to happen successfully without it. And what we would really like is for folks to be able to see, to communicate what it is they're doing with other service providers, and to be really, really concrete about this. What I've said to my staff is, you're not in the car all the time anymore, so you have more time to be sending an email, having a team meeting over Skype or Zoom, Teams, whatever, and communicating what you're all doing to keep that thread constant and to keep that thread moving, so that eventually when we come out of this and we're in phase 3, we haven't just built up every single silo that we've been working so hard to break down over the past 10 plus years. So I would really encourage folks to be diligent about their communication with their community partners. If you don't know who those are, now's a great opportunity to really try and figure it out.
And I should just mention that a lot of this is within an advantage that CIS has, is that it's very much within the existing kind of model of CIS in terms of there being an expectation that the primary service coordinator for a client is aware of what else is going on in the home in terms of services being delivered, and providers connected with that family and is connecting with them as appropriate. So regions have mechanisms for this in place. Granted, it's going to take some ramping up and adaptation for the current circumstances, certainly, but I think there's a lot of good avenues and relationships already in existence to support that kind of collaboration and coordination, and that is, an existing expectation under the CIS model and contract. So that helps. All right, we've got 2 minutes left. Monica, any final thoughts that you would point people towards?
No, I would just, I just would give you one final word of assurance that Vermont's contact tracing team is exceptional. They are expert sleuthers. They're finding the cases, they're talking to the cases, they're talking to all of those contacts that have had contacts with cases. So we want you to have a degree of confidence that should you be in close contact with somebody who's diagnosed with COVID-19, that you will hear from us and we will give you guidance and walk you through it. So, although we really recommend that you screen people before walking into their homes, and we gave you some drafted language there if you need it, that should you be put in harm's way or at risk at any point, you will hear from the health department's contact tracing team, and we'll walk you through that step by step. We've been fast and we've been doing a good job. So we've got your back in that respect for sure. And thank you for all your hard work and being so nimble throughout this bizarre time.
Thanks, Monica. So in terms of some next steps, we'll be having some additional conversation as the state team and with our VDH partners and others to figure out what are additional pieces of guidance to address some of the questions that have come up, and some of more of the nitty gritty around really how does this get operationalized. We'll be talking with CIS coordinators and fiscal agents on our usual weekly check-in call tomorrow. So that'll be further opportunity to talk about really what does all of this mean specifically for CIS in terms of operationalizing it and implementing this guidance. And we will reconnect with VDH as needed for any additional clarification and information. And more to come soon. But thank you everyone for tuning in and for the work that you're doing right now.
Bye folks, thanks.
Bye.